Well, good afternoon, everybody, and welcome to this webinar as part of the Healthcare Innovation Consortium EPR Network webinar series. I'm Hadley Stoller, I'm Chief Exec of HIC. I'll let my colleagues introduce themselves later on anyway, but I'm really thrilled to be here today with Miss Burr Mahmood from Bradford and Jack Philpotts from the Harris Health Alliance. The topic of today's webinar is the invisible infrastructure of patient safety and why digital governance matters. So thank you so much for all of you that are joining. Really good for you to be here. I'm just going to go through a couple of housekeeping bits and pieces before we get started. So because there's so many of you signed up to this one, you won't have the functionality to contribute, and your video and sound is therefore disabled, but you can, and we encourage you to post questions and comments in the chat at any point. When you do that, if you don't mind sharing who you are, where you're from, maybe a LinkedIn link for us to kind of connect afterward, that would be super. The session will be recorded, and you'll receive that link within 24 hours, and you'll also get all of the slides that we're presenting today on email. So yeah, that's just some of the housekeeping. A little bit about HIC and the EPR network and what we do and who we are. So obviously we're a digital health consultancy. We curate and run the EPR network as well as the EPR Summit series, which some of you may have attended, and there'll be a slide on that on how you can join in on both of those later on. But essentially what underpins the work that we do revolves around three key areas. One being discovery, so defining the problem first. Second is implementation, making sure that the systems are being delivered well and that people are actually using them. And then succeeding and success, improving and making service transformation a reality after go live. And they're just a couple of the organisations at the bottom that we've worked with. So yeah, that's just a little bit about us and what we do. So in terms of that community and that network that I spoke about before, the HIC PR network is a space for all healthcare professionals, leaders, vendors, suppliers to kind of come together, collaborate, share learnings, ask the questions that need to be asked, and really be a force for good. And within that, we host a number of regional and national summits and events with our partner Convensis Group. We just had our EPR summit in England, held in Birmingham a couple of weeks ago, week before last, but there are 3 more coming up this year. 8th of September in Scotland, 15th of October in Northern Ireland, and 18th of November in Wales. So would love for you to join us at that, meet the team in person, and carry on the conversation. So without further ado, I will hand over to Jack Philpotts from the Harris Health Alliance to introduce himself and our esteemed guest, Ms. Burr, this afternoon. So over to you, Jack.
Thanks, Hadley. Yes, good afternoon, everyone. It's a pleasure to be with you this afternoon and talk to you about a topic that's, I think, really important to certainly what we do, and certainly in the broader EPR space. So just very briefly, introduction to myself. As Hadley mentioned, I'm currently one of the vice presidents at Harris Health Alliance. I've got sort of 10-year background on implementing digital solutions, predominantly across the NHS, but also a little bit further afield. But those 10 years specifically and predominantly spent in the maternity EPR space with one of our brands, which is K2 Medical Systems. I'll very briefly in a moment kind of explain a little bit about how that relationship is with the broader business now, the Harris Health Alliance. But it was implementing our K2 Maternity Information System, or EPR solution, at Leeds Teaching and Hospital Trust, where I had the fortune of working closely with Ms. Burr. It was a pleasure to work with her during that period. Not sure whether she would say the same, but I'll let her speak for herself in just a moment. But Yeah, so a lot of what I'll be kind of alluding to and talking about today and amongst the conversation is drawn from implementing the maternity information system over that period of time. It's specifically a phase where digital frontline digitalization was a focus, and yeah, look forward to getting into it a little bit more. I'll pass over to Misbah.
Thanks, Jack. Good afternoon, everybody. I'm Misbah Mahmood. I am the CXIO and Clinical Safety Officer here at Bradford District Care Trust. I'm a midwife by background and been a midwife for over 10 years, but worked in digital maternities for sort of the past 7 years. And yes, Jack, it was a pleasure to get to know you because that was my first step into digital maternity. So I was a midwife on the shop floor and then had the opportunity for a 6-month secondment to implement a maternity EPR. I was very naive to believe that it would happen in 6 months' time. And then kind of never really left digital and really fell in love with it. And then progressed on to become the first ever midwifery information officer in England, and kind of paved that path for digital midwives. And the digital midwives role is very important with implementing EPRs as well. So I am now working at Bradford District Care Trust, which is a community and mental health trust, and I'm pleased to say that those transferable skills that I learned and the resilience that I learned with implementing maternity EPR has really helped and supported and shaped my career.
Sounds almost
awesome. That's great.
So
yeah, sorry, go on, Jack.
Yeah, I'll just very much briefly, very briefly, kind of just outline how Harris Health Alliance and, as I mentioned there, Katie Medical Systems, what the relationship is there. So in 2024, we merged 3 sister businesses, all related to healthcare and technology. So Katie Medical Systems was the business that I was part of prior to the merge in 2024, sorry. And the other aspects of what we provide is also genetic and laboratory information management systems provided under the previous business of Genal Genetics. And we also provide primary, secondary care integration via our Quicksilver brand. So those 3 brands or former businesses that were operated separately now form what we refer to as the Harris Health Alliance. And as it kind of says down screen, it's extensive experience in delivering healthcare technology solutions, again, predominantly across the NHS. And we're looking to continue to do that for many years to come.
That's awesome. Thank you. Well, hopefully we'll pick up on some of those opportunities and challenges as well as we talk through. And obviously the theme for this conversation, is very much around strategic foundations for digital care, of which I think, this the patient safety aspect is really, important. Just one more piece of housekeeping that I forgot to mention at the beginning was that my colleagues Colleen and Rhiannon from HHA will be posting some questions in the chat, so please do give your views and opinions on that as we're talking through. Also, just looking through the list of people that are with us, lots of people from various trusts up and down the country. Some neighbouring trusts to you, Mr. in Rotherham and other parts of Yorkshire, and also really thrilled to see some colleagues from NHS England here as well, and also some of the speakers and panelists from the last few EPR summits that we've had. So hopefully we're going to have a good conversation, collectively. So. I guess, Jack, if I maybe come to you first and just ask, from your perspective, what does digital governance between, suppliers and NHS organisations look like in practice, particularly when it comes to safety standards, deployment decisions, and ongoing system changes, of which there are, often many when an EPR is, implemented and optimised.
Yeah. No, it's a fantastic question. It's the digital governance really underpins or ensures what you're implementing, what you're is set out to achieve, achieves what it's set out to. And at the end of this, at the crux of this is really that patient safety aspect. What you do, what you change, what you implement should be always focused around patient safety when you're implementing into healthcare. And when we typically think patient safety, we think of the predominant factors being their clinical skill, staffing levels, and that adherence to process. So in other words, the capability, the capacity of the staff and their knowledge of the systems and processes that they use and follow. But really, it's kind of moving on a little bit further from that now with in the EPR space specifically, where the EPR, in our opinion, or certainly those from where we work, is that the EPR could and should directly or indirectly facilitate all of those factors. So again, the capability, the capacity, and the knowledge of the staff that are there that are so crucial and discharging that healthcare. But it's not always, the EPR is not always perceived as a tool to do exactly that. And you could arguably say that the sole function of an EPR is simply a reliable documentation tool. So I would kind of like ask attendees today what they believe is the intended purpose or use of their EPR, and something that we'll kind of come back to throughout the chat as we go. Because as we know, implementing an EPR poorly or in a less than ideally controlled manner could lead to issues that you get around incorrect or under-optimized configurations and workflows, outdated clinical pathways or decision support, missing user alerts, notifications, and then when we make changes, if they're not done in controlled ways, the impact of that could lead to one of those prior points that I mentioned. And then really at the core of the EPR solution is that how it handles the data, how it makes it accessible to the users in and when it's needed. And it's there where the governance is so important to ensure that the EPR does provide what it's intended to deliver. So really, the simplest definition of governance is how we ensure the system behaves safely today and continues to behave safely tomorrow as it evolves. And I think that as it evolves is crucial because, as we know, we're in that sort of phase where it's digital frontline productivity as opposed to the frontline digitization and how we optimize these systems. And it's not just optimizing for the sake of it. I think we have to do it and continue to do it in those safe manners. It's important to note that when we kind of talk system, we're not just talking about the EPR itself, and it's the process and the people that govern it, really. And I think just expanding on that a little bit further is the digital governance, should be a framework, really, in the sense that that comprises accountability, oversight, and controls to ensure that the clinical system is designed, configured, and changed in a way that maintains patient safety, regulatory compliance, and clinical effectiveness. And then just briefly, if I can, just kind of go into, accountability is the first aspect on there. And I think there's an accountability chain that is well understood and adopted, but I think it mirrors how the system is chosen, selected, and procured. So you have the system supplier or vendor who is accountable to the healthcare provider stakeholders, so who you would normally identify as the buyer. And then they're accountable to their end users, so essentially the users of the system of which they've selected. And then those users are discharging the care and obviously accountable to the patients that use the service. And I would encourage those that work in that space to continue to challenge that line of accountability and continue to think about it. How can it be more collaborative? I know Misba's got some thoughts on how that is more collaborative, how you get the voice of the patient more into how you govern, how we design, how we deploy systems. But really, I think that traditional sort of line of accountability is very much born and mirrors that was the reverse of the procurement, in the sense that the procurement defines requirements that transfer them back and are kind of presented to themselves in as requirements in RFPs and the likes. But we don't want to get into procurement at this point here. But yeah, really, that's kind of how I see governance, and then how that's kind of in there is, or how that is applied to the implementation and the management and the change for EPR solutions for the longevity of their existence, is making sure that you've got that accountability, as we mentioned there, but also the oversight. So the representation, so providing a collective representation of stakeholders with suitable experience and expertise, I think is an obvious thing to say. But that should be a fair representation of the broader multidiscipline team that's required to implement, maintain, and support the EPR. For example, not having a representation from a specialism that is looking to integrate with the EPR is obviously going to make it almost impossible to achieve that in an effective manner. And then for what purpose would you be integrating that if you haven't got the necessary stakeholders involved? And then finally, that third aspect is the controls. So those controls really apply to the design, the change, and the configuration of the system that's being implemented or optimized. So whilst it's unlikely, and as much as we hope it isn't the case, a system that's safe today might not be safe tomorrow. Mm-hmm. I think that's just reflective of the best practices and clinical processes changing. And I think it's our responsibility, collective responsibility, as system suppliers and healthcare providers, that the digital solution keeps up, and that's at the very least, is that it keeps up. In an ideal world, technology that is being explored and harnessed by all parties, and it needs to be by all parties to ensure that it's viewed, it has a comprehensive and holistic view about if and how it can be implemented, not for the sake of it, but to improve systems, process, and patient safety. And we know, I think, final point there is that we know that AI and things like ambient voice technology are big things at the moment. They're big technologies, particularly in this space. And actually, Misba, I know, has got some talks at Rewired around one, particularly around ABT, which I'd be very interested in. I'm hoping others will be too. But it's how you choose, how you select, and then how you identify what is the safe way of implementing that for the overall outcome being improved patient safety.
Yeah, well, that's a very comprehensive answer, Jack, and I loved what you said at the beginning about what do you want that EPR to do for you? What is its function in the organisation? Because actually that is quite an interesting question, because the needs of the organisation changes and grow as well as the EPR solution itself, right? So those that capability, capacity, and knowledge piece that you alluded to really resonated there, because actually you don't necessarily know what you don't know, and it's evolving with you and you're evolving with it, if that makes sense, even if it's a well-established solution. And interesting, we've got a comment here actually from Philip Elvidge from the East of England Ambulance Service. He's clinical lead there, and says that our verbatim, our need for from EPR is evolving. We started as a digital documentation tool, but with the use of mandatories and alerts, we're increasing guiding the access and completion to support patient safety, particularly for a larger number of newly qualified staff with less experience. So it kind of does exactly align to what you were saying. And hi, Carly, good to meet you, and great that you've made that connection with Philip. That's awesome. You're from MSc, aren't you? Yeah, that's cool. So lots of interesting points there, and I guess yeah, Misbah, if I maybe come to you, from your clinical experience, as a clinical safety officer, where do you think organisations most commonly kind of misunderstand, underestimate, or under-resource those kind of patient safety standards, DCB 0129 and 0160, because though in their own right they're incredibly complicated, and you have to actually understand what they are, what they mean, what you do with them, how are they received, and what role do they play, and are they a risk in themselves because they can be super complicated?
Yeah, I think they're very important, and like you said, they can be complicated, but I think from an organisation perspective, quite often clinical safety is seen as a tick box exercise. It's done at the end, and also clinical safety officers are involved too late and they're under resourced, then it makes the safety become quite reactive. So as an example, I'm the first clinical safety officer to join Bradford, and I joined just over a year ago, and I think clinical safety is often then reduced to paperwork, just looking superficially at workflow analysis, and it's kind of then always seen as a bit of a blocker to making, is clinical safety is holding it up. And I think as well, there's, that line between clinical safety and patient safety, because people sometimes don't understand that the risks that are associated with EPRs. So, for example, if I'm on the ward and my blood pressure machine's not working, that's equally as important as if all the laptops go down and I can't access the EPR. And that kind of relates to Jack's point about the use of the EPRs and how that's changing and evolving over time. And I think the core issue is insufficient clinical insight, understanding of the workflows and governance. And as well, just from a personal perspective, I found it quite difficult sometimes with some suppliers to kind of get to the DCB 0129 to say, I need you to provide, your 129, and sometimes the quality of them as well, to be able to then, build upon and do the 160. But yeah, overall, I think the world is changing, and then there is a lot more clinical safety officers now, and in most organisations as well. But I think we just need to change the shift. And I know that nationally there's quite a lot of work going on to align patient safety with digital clinical safety. Yes,
those two worlds coming together is an interesting point, and actually really interesting what you were saying there about the workflows, and actually the community of users within an organization understanding what workflows exist, how they work, and how that EPR becomes an enabler. There's a really interesting question on the chat. I think Rob asked it, and Philip's come back with the question of, are we moving from a digital document system to actually a clinical decision system? So it does go back to that core question earlier, isn't it, about what function, what role is this playing, and do we know about what those workflows are, and have we got an associated clinical and patient safety assessment around it to make sure that that it is safe and that it is fulfilling what is the purpose and need that it's meant to be solving. So yeah, it's really interesting. Gillian, I will read your comment shortly. It's a little bit long for me just to get to right now, but I will come to it. I guess then from both of your perspectives. Sorry, Jack.
I was just going to say on Philip's point, in the sense that I think the clear kind of distinction for how the perspective and the perception of what an EPR should provide or could provide is changes that I think sort of 10 years ago, when we were kind of implementing EPR solutions, we were replacing paper documentation, and essentially the mandate was just replace that performer. So I think the initial implementation that leads, I'm pretty sure we've got scanned documents, probably even sent them to us as paper documentation, and it was a case of digitize that, and it was completely ignorant really of the workflow that underpins that, or kind of underpins how those forms were filled out. And I think that needs to be reflected really in modern EPR solutions, saying or being willing to do more than just be a documentation tool, as it were. And if it can, and it's appropriate for it to do so, provide clinical decision support. But suppliers, and providers need to be aware that our DCB 0129 that we maintain has got hundreds of lines of sort of the perceived risks associated with all of the clinical decision support, making sure that it is right and it's interpretable as intended by the user. The use of color coding, for instance, is always going to infer something to the end user. And it was a point actually at the EPR summit, I think it came up in a couple of the talks given by the team, is that the system also needs to be usable under its most stressful conditions. You can't design a system to be just used well in perfect conditions. Perfect conditions don't really exist. I'm not the one that really should be saying that, so maybe it'll come up a bit later, but perfect conditions rarely exist in the NHS. So if the system can support good use, ease of use under stress, then I think it's providing what it should do.
Yeah, no, absolutely. It's a complex landscape, isn't it? And Gary Donohue's actually posted a really interesting point here around, if a patient's being treated in 2 different hospitals, which he came across only this morning, the process falls down on clinical and patient safety, 2 different EPRs, no interoperability. So the clinical lead at one hospital is calling patients next to kin for them to pass details on to the other hospital. Governance goes out the window, in all respects. And obviously there are national capabilities and plans, particularly around the single patient record, to help solve some of these things. But it's an interesting point, isn't it, when we're talking cross-organisational, cross-boundary, and cross-record, record sharing across multiple organisations. It's a really good point. I mean, with that said, I guess a question to both of you: how do you think suppliers and NHS teams can work together? You alluded to it, Jack, but to ensure those capabilities stay within those regulatory limits, but while supporting that safe, effective, and flexible care delivery. And just while you're thinking about the answer, I guess part of that might be what you were alluding to, which is almost a bit of a co-design and a co-ownership, and creating a solution, like we said at the summit, that works for all. And the reason it works for all is because everyone has been involved in designing what it does, how it does it, and what need it's trying to solve. But I don't know, Miss Bid, do you want to come in and give your view on that?
Yeah, definitely, Hadley. That's just it. It's just the clear roles and shared responsibility, and the communication is really important as well. And I think it's just that, from a supplier perspective, making sure that the healthcare organisation is aware of the intended use of the system, what the limitations are, what the strengths are, what the risks are, so that, we can pick up where the EPI isn't going to match a certain workflow, and what workarounds we need to put in for that as well. And I think it's as well as about treating each configuration as a clinical safety, because sometimes it's branded as this is just a hot fix, or this is just a minor change, but actually it does have a big effect on clinical outcomes, and we don't realise when we just break something here might have a wider impact. So I think that that full overview of the EPR, regardless of the size of the change, is really important. And I think one thing that's really essential, I think, is clarifying the risk ownership. So it's knowing, who is the owner of each risk, but also the monitoring and the compliance as well. But I think it's that joint working, and again, that collaboration and communication. So certainly from my perspective, so I went from being a midwife on the shop floor to then, essentially building and implementing an EPR. I'd never spoken to anybody before, never had conversation with system suppliers, went straight into my midwifery practice. And I think it would that communication was really, really important to kind of understand it from a supplier perspective as well. So sometimes just because we're saying it as a clinician that we want this, we must have this, doesn't always mean it's the right thing to do or the safest thing to do as well. And I think, again, just including clinical safety throughout the full development, which is kind of what we do. And I think as well, we used to, if there was an incident, we would do that post-incident review and really look at that lessons learned, that learning. How can we stop this from happening again? You know, what do we need to put in? And then that kind of comes on to agreeing the risk appetite. So, you know, as an organisation, so from example, from Leeds Teaching Hospital's perspective, we're a really large organisation. Our risk appetite would be very different to a smaller organisation. Obviously, the patients that we care for, the families that we care for is very different, and our risks and incidents that we have would be very different to a smaller organisation. So I think, again, from that communication with the supplier perspective from the outset, is agreeing that risk appetite. And I think, again, just summarising, I think safe flexibility comes from that shared clinical governance, and it's not just, you know, stretching the systems beyond their intended use, or making like that's the supplier's fault, that's your fault, blah blah blah. You know, it's that working together for that shared ownership, because our ultimate goal is patient safety, and it's how can we do that together.
Yeah, 100%. Yeah, Jack, any points to add to that? I think I agree very much with what you said there, Mr.
Yeah, no, I couldn't agree more. I think when we say communication, you know, I can add a bit more context around there in terms of quite often you'll get there'll be communication from customer to supplier around, you know, this is what we want. And the supplier will go away and they'll say, well, this is how. So you get the what, and then the supplier gives the how as to, you know, a technical interpretation. I think interpretation is key there. But I think what is often missed is the why. You know, why is it that's required or is desired? And then that can kind of lead to a lot more sort of beneficial sort of investigations, discoveries around, you know, what is it that's trying to be achieved, as opposed to, you know, implementing something in isolation. And I think that's the key piece. And on the communication side, the intended use of the solution also has intended users. So we have users that we develop our solution for, and each EPR does. And obviously, the broader the EPR, the more intended users it has. And that's why it becomes really important that when a requirement is communicated, it's communicated from the perspective of a user. So as a midwife in Misba's position or former position when we were implementing it, it's really important that is, because then it keeps it the requirement or the need rooted in a clinical setting, and doesn't let it be abstracted into that technical space. And, you know, keeping it in that clinical space, you know, make sure that everybody appreciates why something's being implemented, why something's being considered, and then how you then govern that more broadly, and you get more people, whether it's by broader user groups of a solution or other disciplines within the organization. I think that's important, that transparency that is part of good communication.
No, absolutely. There's some great questions, by the way, coming that all support exactly what we're talking about here. Yeah, well done, Julia. I agree. Functional scope of the EPR is important too. I completely agree. But I feel like what you're describing is almost the next part of what I wanted to ask you about, really, which is that people, process, and technology part. Now, there was actually a really cool question in the chat earlier on that I said I would come back to from, I think it was Gillian, who was asking about the use of Microsoft 365 for security and collaboration, which maybe we can come on to. And there's also a question from Barbara from Derbyshire around, you know, what makes a successful maternity EPR implementation as a digital midwife, especially for someone like Barbara, who's new to the role, which maybe you can also answer, Misbah. But I guess from your frontline experience to try and cover off both of those points, you know, where did digital systems, you know, commonly clash with those kind of established, you know, maternity workflows, and what part of that people journey and that process, you know, and technology component, you know, comes in, you know, where does that pressure point kind of stop, and where do those three kind of come in to be an enabler as opposed to a blocker?
Yeah, I just wanted to just start off and say that digital is an enabler, it's not a fixer, and the EPR isn't going to fix everything, and you can't overlay a digital solution over a poor process and expect it to work. So certainly at Leeds, when we went onto started our EPR journey, we had two hospital sites that worked very differently, and we had to do a lot of consolidating the process, reviewing that before we layered the EPR on top of it, because otherwise it wouldn't have worked. But I think we know maternity care is complex. There's a lot of scrutiny on maternity services at the moment. You know, we're expecting a lot more and more from our EPRs, from our midwives in terms of documentation, and most digital systems do struggle with that. So as midwives, we depend on clinical narrative and context, but digital systems sometimes prioritize structured fields and templates and workflows, and there's this sometimes mismatch forces midwives to use workarounds like parallel notes. You know, I'm sure there's still some community midwives that carry paper diaries around, and you know, and using free text instead of using the structured data. But I think as well, the maternity care, we value on continuity of care for our patients. Yet most EPRs rely on episodes and tasks, which then kind of don't follow the continuity of care that we provide as midwives. And I think as well, wider to the EPR, there's other factors that we need to consider. So, you know, we have a lot of community midwives that are doing home visits that have got poor signal. They're pressured in between visits and in between clinics. And with the digital expectation is that we have to be constantly connected, and that real-time documentation. So sometimes offline support is lacking. However, we know that the offline mode within K2 really does help support our midwives. Therefore, it doesn't, you know, they're aware of the areas where there's lack of connectivity. So it makes sure that they are aware that they can use the offline mode. I think from a intrapartum perspective, you know, on labour wards, we need rapid documentation and clear prompts, and systems that separate CTGs from narrative. And as well, I think it's looking at that cognitive load, because quite often, you know, you could be in a room with a family for, you know, 12 hours on a night shift, and you know, 4 o'clock in the morning, those kind of situations, and just that helicopter view and that human factors element as well and to support our workforce, because we want the EPR to work with you, not against you. And I think as well, the general thing is just around is maternity. The sticking point is usually processes that fails to connect people and technology. And I think that's the bit that's really important, is that the people, process and technology all need to be aligned for a successful EPR, because you can have the best EPR in the world that's all singing and dancing, but if your people are not on board, and you don't have the appropriate processes in place, it's not going to work.
Yeah, 100%. Yeah, no, totally. All these things have to go hand in hand, don't they? Otherwise, you know, it's not going to work. And by the way, Barbara, just to answer your question around, you know, sharing experiences and best practice, etc. When we finished our kind of conversation, there will be a QR code for you to come and join one of our specialist interest groups, where people like Misbah and others, you know, will be around the table, you know, to help share some of that with us. So. Hopefully that helps. I guess, Jack, from an industry and product perspective, then, you know, how do you recognise the point where flexibility for you know, local needs becomes complexity, and when does that complexity start to introduce clinical risk? Yeah.
No, that's a good point. It's the it's the adage of if putting on multiple options within a system, how are they supported, how are they maintained? So that what you kind of get into there, Hadley, is does flexibility equal complexity? Because what we know is complexity equals risk. That's just simple fact. And you know, from experience, our legacy solutions or that we provided, not just into maternity, but from across our sort of wider product set, there was always a desire and a need, certainly perceived from our perspective, to be able to provide highly configurable, and really back then it was customized and solutions. It was a selling point of what we did. And something that we've tried to support, but now in a more controlled way. So sort of architecturally within the solutions that we provide, make sure that there's controls in place, but enriching the product with a broad and deep configuration layer that has all the relevant controls, but allows us to maintain a core solution at the heart of it. And the benefits of that meaning that there's ultimately safety in what we're doing, because essentially we've got the core system and a remit to which it's tested, it's viewed, as opposed to multiple systems, as it were. And I think that's the really key bit that we've learned over time, and we're still on that learning curve for sure, as we understand how we make it more and more suitable for more and more organizations. But really coming back on the governance bit of it is that, you know, we're attempting to govern our products with wider user groups, and it's something that we've done less successfully than we'd have liked over recent years. But we absolutely acknowledge and appreciate the value of the more people that we can have and engage with, the better. And we can bring those people together with the solution, as opposed to have each one of them have a solution that's fit for their needs for now. But it's that point I made earlier around the processes and best practices change so quickly, that we need to do it all together, as opposed to in isolation of one another.
So I guess a question, you know, and Julia agrees with you, by the way, Jack, saying that user groups are essential to reach consensus as far as possible regarding changes and developments. But I guess maybe for you, Julia, you could put your comments in the chat, and obviously everyone else as well. You know, do you think that technology, you know, should be adapting to existing processes, or should processes actually be harmonized to safely standardize the technology? I'm sure the answer is probably a bit of both. You've got to be flexible, but you know, how do you manage that? What does that look like? And you know, which camp do you sit in on that one?
As a supplier hat, we'd like the process to be aligned to what we do, but that's not, you know, we're not the ones that that can say at all. You know, it's kind of what we were saying before, is that, you know, a need or a requirement is identified, and then it needs a technical solution. Unless there's in-house teams in each NHS organisation that are going to have these technical capabilities themselves, you know, you're not leveraging what industry can provide if you're doing that. And I think that's where we're seeing less and less of that as we move forwards. It is just a compromise, and the more people, the more opinions, and the more voices that, you know, you're enabled to be heard on those things, around what the way forward is. And then also having part of the process in here, and the governance again, is the feedback. If it's implemented and it's not perfect, or it hasn't achieved what it's set out to achieve, it's being able to identify that as quickly as possible, and, you know, making you know, being able to facilitate further change, because the confusion sometimes is governance equals bureaucracy. And that's what we also need to avoid, is that, you know, there's flexibility and purpose for and ultimately the purpose at the end of the day is safe and effective solutions.
Absolutely. Totally. And again, you know, just going back to the whole theme and topic of this, you know, webinar, where we're talking about you know, the invisible infrastructure, and why that digital governance you know, really matters. I guess you're answering the question, aren't you there, Jack? And Ms. I don't know what your views are, and you know, lots of comments actually here in the chat around you know, making sure it's done the right way. It needs to be the easy way, and you know, otherwise we're asking for those issues, and complexity and workarounds can be found. So, you know, good workarounds to poor systems is what you know, Kay has said. But you know, what do you think, Miss? You know, which one comes first, and how do you navigate that to have good, strong governance that is safe, and effective as a tool for enabling, better care.
Yeah, I think the best approach is that balance between technology and existing clinical workflows. But I think it's really important to understand how care is actually delivered, not just what's written in a policy that somebody decided. And
Yeah.
also understanding the why, because quite often, we are reactive. So we'll put in a process because we had an incident 10 years ago that's never been repeated again. And it's
Yeah.
understanding the why. Why are we doing this? Why is it important? And what are we getting from this as well? And I think that is really important for the collaboration between clinicians and operational teams as well. So it's striking that balance as to what technology should we support for safer care, but also where do we need to change and adapt? Because, like I said, just because it's written in a guideline or a policy doesn't mean that that's what people are doing on the shop floor. And again, it's those other factors around it too. So in regards to we can develop a full digital workflow, but it might be in the bottom of the antenatal clinic and they've got no reception, and the signal keeps dropping out, so that workflow is not going to work. So it's understanding the wider implications as well, and again making sure that these are all documented as part of our hazard logs as well, and that it's governed and is governed effectively. And again, just that clear communication with the suppliers to say, this is what we want to do, however it's not going to work in this way because we have issues with connectivity hardware, as an example.
Yeah, no, 100%. And if you remember that slide that I presented just at the very top of this webinar with those three processes, discover, implement, and succeed. You're talking about the discovery there, aren't you? Defining that problem first. And if everyone that's joined us today and listens to this afterwards takes one thing away, my plea would be to ask that question: why is this, and is this right? Is this really what's happening? Is this really a problem that we need to solve? Or is it something that's just kind of, that we're trying to solve, but there's no real reason for it? So yeah, and Gary agrees. He says you've got a great point of view there. So that's good. I guess just in terms of, because we're rapidly running out of time, I'm sure we could talk all day about this. It's a really interesting topic, but in terms of kind of patient safety by design, I guess for both of you, maybe come to you first, Jack. How do you assess whether a proposed digital change is likely to improve patient safety or actually unintentionally compromise it?
Yeah, that's a good point. I think going back again a good few years, probably 7 or 8 years ago, when we were implementing the maternity system, we did actually, and what didn't happen in this instance is we didn't really ask for the why and think about the broader implications. So at the time, the maternity services data set was new, and it was becoming core national requirement to report. And one particular trust was struggling with their data quality, and we had the benefit of a very well defined specification for the data set. And the thought here was that why don't we just implement all the business logic, all the business rules into the front end, so that the user, is forced to document stuff in a way that is not going to have rejections and error validations and the like when they submit their data. And it was a really easy implementation, a really easy change for us to make. As I said, the specification was there and the team were able to implement it perfectly. What really hadn't happened is, again, we'd isolated this requirement, this request from the clinical setting. And then when the users began to use that system, they were being presented with errors and validations and the like in the front end that really became a distraction, and in some cases prevented them from documenting the care that they needed to at that point. So needless to say, that was a very quick undo of what was implemented there, and a more holistic view was then taken. And I think that's kind of what is, always stands as an example in my mind, as to always making sure that we're asking that why, and you never isolate it from the clinical setting in which the system is intended to be used.
Yeah, absolutely. I guess before I ask the penultimate question, I suppose, to you, Misbah, before we kind of start wrapping up is, obviously with your maternity hat on, could you share any examples or instances where, not implementing a digital feature was actually the safer choice? And what informed that decision? What was the outcome? How did it kind of, work out?
Yeah, I think there's been many times where there's been a proposal of a digital solution and we've chosen not to implement it. And that's because sometimes it might be seen as being too complex or the time wasn't right as well. Because I think as part of this, it's really important that we understand and protect our workforce and our patients as well. So I think it was a time when there was a lot of change happening, that we didn't really fully understand the development or didn't have the time to do that collaboration work to understand how this would impact other people. So I think it's really important to do that collaboration work. And sometimes I think, like I said right at the beginning, I was brought onto the project to implement an EPR in 6 months. That didn't happen because it wasn't safe to happen. And sometimes it's important to kind of say no. And I think, within an NHS organisation, sometimes it's like you have to achieve this deadline, you have to do it by this date. But sometimes it's having the support, and I think the governance and having the support from management and everybody else to say, no, actually, we're not pushing back. We're not gonna implement this. We're going to push back. And I think again that communication with the supplier as well, so that you're all on the same page. But just picking up on the earlier point from what Jack said, I think it's important as well that we're understanding when we're designing it how it's going to work in practice. So when I'm sat in my office testing the EPR, it works absolutely fine because it's just me doing it. Whereas when I'm on the ward at 6 o'clock in the morning and the emergency buzzer's going off and everything's happening, I don't want to do 5 clicks. I want to do 2 clicks. And I think it's really understanding that as well. And sometimes I think it's finding that balance, because I think sometimes is that we need to do this for data quality so that we're capturing the data, but actually, how does that really work in practice?
I think my takeaway from both of your points on that, in terms of how we design patient safety it's the P word, isn't it? It's people. And actually, Kay spoke about floor walking, actively recording how things are done in the real world, not how they're documented as being done. And that's meant that they've had in Kay's trust, a much better idea of how systems need to work. And Philip also said that surveys are commonly used. The best feedback that they get on EPR comes from a super user group, around 30 staff from across the region who have a good feel for their areas, opinions, and obviously their own as well. So obviously involving people, I think that's the key message, isn't it? It's designed and got to be designed by the people using it for the people using it, and that technology then becomes an enabler, and as that foundational piece of governance, it kind of, do you think it's fair to say, Ms. Miller, it kind of writes itself, because by that point it's really kind of something that's just almost just a tick box exercise, isn't it? Because it's been developed from the ground up.
Yeah, it definitely 100%. And I think it's when it is developed from the ground up, you can see that within the EPR, your documentation will increase and the quality of it will increase. And quite often, we'd always get people coming to us with digital developments that they wanted to use, and how we could adapt the functionality within the EPR to support our workflows rather than getting another system. So for example, we adapted the appointment functionality within K2 to support our induction of labour appointments, our fetal assessment, and then we use the reporting functionality, sort of like a diary management, which is something that wasn't really advertised to us, but we really worked with our team and worked with K2 as well to kind of develop that functionality to make sure it was streamlined in the workflow.
No, totally. Before we wrap up, folks, because time has just flown by, just a quick one back to both of you. One key message, one call to action, one key thing that you want people to leave today's session with, some advice or something that you'd like people to just, maybe some homework when people go back to their respective organisations, or an ask of the community that we've got on the call with us today. I don't know, Jack, do you want to go first? Give Ms. Rell a bit of time to think about that one.
Yeah, absolutely. I mean, collaboration between supplier and provider. I was at the, taking us away from maternity just like I was at the an ambulance leadership conference last couple of days with a partner there who we were working with to provide EPR solution into ambulances, and they had the same perspective of us, that the information sharing sometimes not as clear between supplier and provider. So the DCP 0129 is always provided to the provider from the supplier, but that visibility of the 0160, I think the more we can engage and the earlier we can engage more people, more perspectives, the better, so that it's not, okay, and how does this change that we've just made, how's that going to impact? It needs to be more in the design phase.
Yeah,
absolutely. And I think having it to be, again, for its intended use in its non-ideal situation. So actually notice that Harry's on the call, or was on the call anyway. His talk around their emergency department solution, and it needing to work under its highest pressure. But very, very difficult to simulate that in a setting. But if you bring the right people together, you will get the right opinions and perspectives. That can be, you can guarantee that.
Yeah, absolutely. No, Harry's still with us. He's still on the call, just check. But yes, the design is really important for sure. Misbah, your plea, call to action, final thought.
I think it's just that consideration of people, process, and technology. Technology isn't the fixer; it's an enabler. And again, communication. That good, clear communication with the people that are going to be using the system, the patients that are affected by it. The work with the suppliers as well. I think that is really important. Making sure you put everything on your hazard log.
Absolutely. Yes, absolutely, of course. It's interesting. We called, we kind of called this the invisible infrastructure of patient safety, but the more that we've spoken about it today, the more I think it's maybe not so invisible. I think it's actually very visible, and it's probably a key foundation, isn't it, to making sure that these systems are useful, usable, and used. So there's a couple of final points then, just to kind of talk through. So for NHS colleagues on the call, if you would like to get involved in one of our specialist interest groups, these are free to join, and you're more than welcome to come and join our growing community. It's a way of connecting clinicians, NHS leaders, tech providers like K2, and others in our network to share insights and experiences. It's opportunity to influence the design, optimization, and safe use of EPR systems, and to also drive forward innovation, improve workflows, and enhance patient care. So please do scan the QR code. We have a maternity specialist interest group up and running. These are chaired and attended and led by NHS colleagues. More are on the way, from ranging from EPMA to paper to digital to AI and kind of all in between. So please come and join us and have your say and be part of that community. And of course, continue the conversation with us at the next EPR Summit, which is all the way up in sunny Scotland, in Glasgow, on the 8th of September. It'll be great to see you there, and please look out for that. And then I think the last slide is just, I might just cover it if that's all right, Jack, just to come and meet the K2 team. The folks are on stand E10 at Rewired. If you scan that code, you can book in some time and kind of take their interoperability challenge. That sounds exciting. Jack's email and Katie, who introduced herself before email, was just on the screen, but we will share these slides with you after the call anyway. I can see some more comments in the chat. I think we're just sharing links and all that kind of thing, so make sure you're engaged with that. So lastly, but certainly by no means least, thank you to Jack and the K2 team for working with us on preparing for today and coming along. Thank you to Misbah for your contributions, and of course thank you to the extended HIC team, Charlotte, Rhiannon, Colleen, and everyone else in the background that have worked super hard to make today possible. So thank you very much. That draws us to a close. Have a great afternoon, and we look forward to seeing you all again really soon. Thank you very much.
Thanks, everyone.
Take care.